Hi, this is E. David Crawford. During the next few minutes, I would like to share with you content of a manuscript we had published called Radar 3 in the Journal of Urology. But before we begin, let's review the Radar history. Radar 1 was initiated in 2012. We had a working group that was formed to examine an unmet need of diagnosing metastatic disease with appropriate imaging and timing. We reviewed literature and found out that there really weren't any consensus about guidelines, so therefore we came up with them. Basically, what we did is that we divided these things into three buckets on when to diagnose advanced disease. The first was newly diagnosed patients. We noted that over the years, a number of men were being scanned with low-risk prostate cancer, and it was basically a waste of resources. So we looked at the data and came up with this, that you should scan people when you had two of the three things present: PSA level greater than 10, Gleason score equal to 7 or above, or a palpable nodule. In the area of biochemically recurrent disease, we looked at when to scan when the first PSA was between 5 and 10. If that were negative, then when it was greater than 20. And where a lot of the time was spent was in the M0 castrate-resistant disease. There's a lot of controversy about when to scan, but look in the literature, we found that the best time to scan is when a PSA was greater than 2 and the patient had castrate levels of testosterone. If that scan's negative, greater than 5 then, or doubling time every 3 months. Radar 2 basically built on Radar 1 and all the new exciting agents out there. And our goal was to provide a consensus on sequencing combination and also something, a title we came up with called therapeutic layering. The working group recommendations, basically, therapeutic layering is like using ADT or a second generation pathway inhibitor in combination with new agents in men who had, at least at this point, CRPC. So the layering is, we start out with ADT, we continue ADT, then we add things like these androgen pathway inhibitors, and then on that, layering immunotherapy, targeted alpha therapy, and chemotherapy. So the final recommendations are that we have all these new drugs. We have the immunotherapy, sipuleucel T. We have androgen pathway inhibitors, abiraterone, enzalutamide, now apalutamide, and soon darolutamide, targeted alpha therapy, radium-223, and of course, chemotherapy. So let's move on to Radar 3. Radar 3 was based on the recent development of next generation imaging and the impact that has on prostate cancer. And basically, what we know is that the next generation imaging, novel imaging, provided the opportunity to find prostate cancer early, particularly in biochemically recurrent patients, and also to evaluate men who were in the NMCRPC space who failed hormone therapy to see if they had metastatic disease. The players out there are several, but we only focus really on several that are available in the US, and that is fluciclovine and probably in the future gallium PSMA. Choline and acetate PETs are approved and out there, but the problem is, the challenge is they have a very short half-life, and you almost have to have a cyclotron in your backyard. If we look at the scans that are out there in Medicare coverage, we see that fluciclovine is approved, so is choline and FDG PET. Gallium is not yet approved in the United States, although it is used extensively in Europe and Australia. So the Radar group also felt that the CRPC nomenclature probably needs to be looked at and perhaps changed based on the results of and the availability of this next generation imaging. And what we see here is that in patients who have non-metastatic, and we changed the term to endocrine-resistant prostate cancer from castrate-resistant prostate cancer. Now we call it non-metastatic ERPC. If you have conventional imaging and it's positive, then it's metastatic ERPC. If you have a patient who has non-metastatic ERPC determined by next generation imaging, we give that an asterisk. And then if this patient turns out to be positive, they become mCRPC with the asterisk being positive. The point is here is we're using the imaging and next generation imaging to further define the clinical stage of the patient. So this is basically what the conclusions of the RADAR 3 group was. The blue is RADAR 1. Remember, our goal was identifying metastatic disease, and we had the newly diagnosed patient, and we had these 3 criteria if you had 2 of these scanned. And we also felt that if you had a patient who you felt at risk of having metastatic disease, conventional imaging is negative, then you should use next generation imaging. For example, a person with a PSA of 40, Gleason score of 9, and every biopsy positive, negative imaging, we all know that patient's at high risk, and that would be a good one to do. Biochemical recurrent patients, again, we went over this earlier, PSA, first one between 5 and 10, 20. Here's where a major difference is, that this new imaging allows us to detect disease when PSAs are low, even above 0.5. So if you're going to do something, if you have something that's actionable, it certainly is worth to consider next generation imaging. M0 castrate resistant patients, we know that we've had a couple of drugs recently approved, apalutamide and enzalutamide in this space, based on conventional imaging. Now we have ways to detect the disease with next generation imaging, where we might consider that and diagnose metastatic disease or local recurrence or things like that. But we would only do this if it would be actionable. If the patient did have negative scans and met the criteria for progression at M0, or as we would like to call it now, NMCRPC or NNERPC, then one would consider treating that patient. You could do the next generation imaging. If it were positive, again, you could still treat them even if they did have disease, because the approval was based on the original scanning. And M1, the next generation imaging, might play some roles when you suspect that there's progression on scans that are not seen with conventional imaging, or changes in symptomatology when other scans are negative. So let's look at a quick case. An 82-year-old man, good health, had a radicals at the age of 70, PSA 28, Gleason score of 9. He had radical prostatectomy, organ confined. He got 6 months of adjuvant ADT, went 9 years, and then his PSA went up to a 3.5. Conventional imaging was negative, but a fluciclovine scan, an oxygen scan, showed mesorectal fascia involvement. He was treated with radiation and did very well. His PSA became 0.01. So if we actually look at this case here, here's the oxygen scan, here's the area of interest. There's no prostate, as you can see here. This was treated with targeted radiation. The patient did fine. So in summary, RADAR 3 really incorporates the next generation imaging, how to usefully use it in the management of men with prostate cancer. Thank you.